Welcome, everyone. Good evening. Thanks so much for joining us on behalf of Dr. Groot and myself. Really excited that you're joining us for this topic. My name is Roy Strowd. I'm an associate professor in Neuro Oncology at Wake Forest, and here with Dr. John Groot, professor of Neuro Oncology at MD Anderson. Dr. Groot, excited to lead this webinar with you.
Thank you.
Got you on mute. Great. Well, we'll get started. We're going to talk about LITT, laser interstitial thermal therapy, and its application in neuro oncology. And we have a lot to cover, so we will get started. Dr. Groot and I both serve as consultants for Monteris Medical, and tonight we will really speak with you from our perspective on the use and incorporation of LITT in our clinical practices. And any relevant disclosures are here. So what are we going to cover this evening? We'll start with a brief overview of LITT, of laser therapy in neuro-oncology. With an eye to the neuro-oncologist, we have a lot of different people in the audience and attending, anywhere from residents, fellows, up to very seasoned practitioners in neuro-oncology and radiation oncology and neurosurgery and other specialties. And so we'll try and hit the highlights of LITT and how it works and what the experience is for patients. We will spend the bulk of tonight talking about the clinical data, what evidence is out there for LITT in terms of its activity as a surgical tool, in terms of its safety, impact on quality of life for our patients. And then we'll end with a brief case review of how Dr. Groot and I have integrated LITT into our clinical practices and how you may think of integrating the data you hear into patients that you see. So let's start with just a summary of what is LITT used for in neuro-oncology. What are clinical applications for laser therapy? We see it used for gliomas, metastasis, and radiation necrosis. In the glioma world, we'll talk about the data for LITT use in unresectable newly diagnosed gliomas, unresectable recurrent gliomas, and in patients based on performance status. We'll talk about the data in brain metastasis, both in newly diagnosed and recurrent brain metastasis, as well as radiation-induced necrosis. And we see LITT used across the spectrum of neuro-oncology cases. And you can see here some MRIs of where LITT can play a role. We think about it frequently for symmetrical lesions, where we can get a good area of ablation, but we also can see LITT used for asymmetrical lesions. We think about it for difficult to access deep lesions, but we'll also talk about application when there are more than one lesion and multiple passes is possible and can be used. And we'll focus on some of the data around the use in METs and radiation necrosis. So let's start with an overview. So LITT, laser interstitial thermal therapy, is a thermocoagulation intervention. It is a minimally invasive procedure that is performed very similar to a stereotactic biopsy for those who are unfamiliar with the procedure. And it begins in the very same way. In the operating room, stereotactic frame is placed. And for many patients, this begins with a stereotactic biopsy, which is one of the benefits of LITT. This can be used as both a diagnostic procedure and then transitioned to a therapy. It's performed through a small burr hole in the skull, very similar to a stereotactic biopsy. In the operating room, a laser probe is inserted and docked onto the stereotactic frame and then can be used for the treatment. And the treatment is delivered either in the operating room through an intraoperative MRI, or the patient is transitioned to an MRI suite where the treatment is administered. We tend to think of ablations to an area of 4 centimeters in diameter, but multiple trajectories are possible and can allow even larger areas of ablation to be performed. And it is a minimally invasive procedure. So after the procedure, the skin is closed with 1 or 2 sutures and patients are discharged home, frequently with an overnight stay the next day after operation. Lasers have been used in oncology and in neuro-oncology, and there's been interest in clinical applications for many years, but we really didn't see their use until the advent or incorporation of MR thermometry. And so for those who are not familiar with this, this allows for real-time assessment of the zone of ablation and to titrate the treatment in real time to the patient and their individual lesion. This procedure uses phase change from the MRI to calculate real-time temperatures in a three-dimensional plane. So you can see in each plane the area that is being heated by the laser with about an 8-second delay. A thermal dose is confirmed using a complex mathematical model of thermal injury that takes into account both the temperature and the time. And we tend to think with laser therapy, both cell death in terms of temperature and time, and those two parameters are important in determining the thermal dose that's delivered to the lesion. We tend to look at pictures and think of that thermal dose in according to 3 lines and defining different zones of ablation. The white line of coagulated tissue, the blue line, which you can see here on the MRI, is the zone of dead tissue, and the yellow line, a zone of potentially recoverable tissue. And this may be an area of blood-brain barrier disruption, which is an area of current and future investigation that we'll talk about. And we'll talk about that here. And primarily, we think of laser therapy LITT as a thermal coagulation procedure and tool in the operating room, but there may be additional mechanistic effects that are currently being explored. 2 really nice papers, actually really like this paper from the Washington University group, exploring the potential for LITT to have blood-brain barrier disruption properties. Here you're looking at K-trans graphs. This is an MR marker of blood-brain barrier disruption, and we see elevated K-trans early after LITT therapy that declines within the first 2 weeks and may persist out to 6 weeks. So there may be this area and potential window of blood-brain barrier disruption around the lesion that could be therapeutically beneficial in an area of future study. And there's a lot of interest in using LITT for potential immune activation and immune adaptation effects. Hyperthermia induces an immune response, and so a lot of interest in this area. Dr. de Groot, I know this is an area of interest for you. I don't know if you have any other comments about these areas.
Thank you. Yeah, I think this is a really exciting opportunity. There's, as you can see from the date of the publication, dating back a decade, there's some really great evidence that hyperthermia could actually induce a pro-tumor anti-immune response. So it's very exciting to see this and put into future trials.
So a number of well-established mechanisms and then some area of future study that I think are very interesting for moving forward. So let's spend a little bit of time talking about the existing data and evidence for the activity and safety profile of LITT. And we'll start with a summary. And these next 2 slides, I think, are really important in summarizing the existing data on LITT. LITT's been used quite a bit, a ton, over the last 10 years in patients with brain tumors, both glioma patients, brain metastasis patients, and radiation necrosis, and in epilepsy. Since 2014, as you can see here in the published literature, over 4,000 patients have been treated with laser therapy and exist in the published literature, and even a larger number have likely been treated in clinical practice. And we see here a very impressive early adoption in the mid-2010s, and in the last year, just exponential expansion in the use of LITT and publications related to LITT. There's a substantial amount of data and evidence surrounding LITT in the literature and in clinical practice. What about safety? Safety has been explored extensively, and in general, LITT is a very safe procedure for each of these indications: gliomas, metastasis, and radiation necrosis, with very low rates of intraoperative injury, CSF leak, and other perioperative complications. Risk of neurologic deficit is quite low. We'll look at a couple of papers looking at risk of permanent neurologic deficit, and we've really seen declining numbers in the risk of permanent neurologic deficit with additional experience and expansion in the technology related to the laser, and the ability to align the treatment field outside of motor networks, but published rates of neurologic deficit somewhere between 2 and 9%. Low risk of bleeding, intraoperative complications related to anesthesia, infection, edema, pain, tissue injury, and weakness. LITT's a very safe procedure, I think, for our patients. And so we're going to walk through 5 studies that I think Dr. Groot and I think are very important studies. This first one, I think, is one to write down and review, a very important paper, and we start with that as something I think neuro oncologists should be aware of. And this is the initial publication of the LANTERN registry. LANTERN here stands for Laser Ablation of Abnormal Neurologic Tissue Using Robotic Neuroblade System. And this is a prospective registry study of patients treated at a number of centers, a multi-institution study treated with LITT. This initial publication, published last year in 2020, reviewed the first 223 patients treated with LITT on the LANTERN study. And again, this is a post-marketing study with prospective data, well annotated, rigorously collected quality of life and safety data in the real world setting, so in patients that we would treat at our institutions. And what we see from this publication is we see that patients are being treated across the disease states that we treat, about 131 primary brain tumor patients and 92 metastatic tumor patients treated and enrolled in the LANTERN study. The vast majority of the primary glioma patients being high-grade gliomas, but also low-grade meningioma and other tumors that we may see, SEGAs and tuberous sclerosis and others. The metastatic tumors are split between recurrent disease and radionecrosis, and often this is something we don't know when proceeding with LITT. And again, this is the benefit of allowing a biopsy to determine what the lesion is, and then offering a therapy for either recurrent metastatic disease or radionecrosis. And some important data to come out of this study. One is this is a minimally invasive procedure that requires a short hospital stay, a median length of stay of 33 hours, so about a day that patients are in the hospital. Most patients had very little time in the ICU. Discharge rate to home quite high, 83% of patients, and a very low readmission rate. So this is something we can get our patients in and out of, and the data supports that. The adverse event rate is low in patients treated in the LANTERN registry, 4%, with stable or improved KPS of 50%. And I think importantly, this study really allows us to look at quality of life data. Quality of life data is collected prospectively in this patient population, and we see stable quality of life based on the FACT-BR and EQ-5D, with improvement in patients' mobility, self-care, and ability to participate in activities in the 3 months to 6 months following laser therapy. So this is really important data that we can take to our patients and I think review in tumor board. In terms of survival, we see median or 12-month survival in patients with primary metastatic disease of 74 and 70%, which is what we would expect of this population. The second paper that we'll review here is a single institution study of 238 patients treated at Cleveland Clinic. And this is an important study in looking at changes in practice and our experience and the experience with LITT over time. This is a retrospective study of 238 patients treated with LITT at Cleveland Clinic. And this group divided the population into an early LITT group treated between 2011 and 2014, and a later group treated between 2015 and 2018, and allows us to look at experience and the benefit of experience over time. So what are some take-homes from this study? Well, this group reports what I think we've seen institutionally here, and I suspect Dr. Groot at MD Anderson as well. Early in 2010, 2011, we see LITT being used primarily for high-grade gliomas and maybe a few low-grade gliomas, and that's where the initial experience was gained. We see an increasing use of LITT for low-grade gliomas. You see here the green bar, and an increasing experience in the use of low-grade gliomas over time. And more recently, we see rates of clinical application of LITT for radiation necrosis and brain metastasis really equaling, if not surpassing, that in primary gliomas. So this is a therapy that we see offered and can offer to our patients with both newly diagnosed glioma, recurrent glioma, and metastatic disease or radiation necrosis, and that's what we see here. In terms of outcomes, these graphs show overall survival outcomes by size of a tumor treated, and we tend to think of that 4 centimeter mark as a reasonable cutoff for treatment. This is a controversial area within LITT, and some would say you can treat larger areas. Others use this sort of 4 centimeter cutoff, and this is one of the reasons. This study looked at overall survival for patients with lesions greater than 4 centimeters and less than 4 centimeters. In those with glioblastoma, high-grade gliomas, we see improved survival in those LITT-treated lesions that are less than 4 centimeters, but we don't see that difference for metastasis, low-grade gliomas, or radiation necrosis. And I think some of this comes down to the experience of the surgeon and the clinical indication for the patient. Importantly, on the next slide, this study did look at changes in outcomes over time. Again, with this early group between 2011 and 2014, and the latter group between 2014 and 18, we see operative times decrease with increasing experience from 6 to 3 hours. Complication rates, very importantly, decrease with permanent motor deficit of 15% in the early treatment period and 4% in the latter period, representing both, I think, improved surgical experience, better pre-treatment planning, as well as some improvement in the technology of the laser. And importantly, patients with poor baseline KPS had worse survival outcomes after LITT. And this is something that we do talk about in our tumor board is the functional status of the patient as we plan laser therapy. And we are looking for those good performance status patients, which tend to do better with LITT and following LITT, and these data do support that. So Dr. Groot, I'll turn it over to you to cover the next few studies.
Great, thank you, Roy. So I'm going to talk about 3 different studies here. The first one was published in early 2019 by Dr. Shah and colleagues, describing a single center experience from the University of Miami. And the objectives of the study were to evaluate the series of LITT cases to determine the safety and outcomes of the LITT procedure performed by an experienced neurosurgeon. They looked at about 1,400 patient records and then identified the cohort of patients receiving LITT. So there were 91 total patients and 100 LITT procedures with the oncologic indications that you can see here, including brain metastasis, newly diagnosed, and recurrent GBM, and some radiation necrosis. So the study primary outcome was to evaluate the extent of ablation, the time to recurrence, the local control at 1-year follow-up, and overall survival. And the secondary outcomes of the study were to evaluate complication rates. So the figure on the left and one of the first columns on the table on the right are showing the extent of ablation for each of the different pathologies that were treated. As you can see, median extent of ablation was greater than 80% for most of the pathologies. Obviously, the extent of ablation was greater for newly diagnosed GBM than in recurrent relapsed GBM, which we think could be because there's much more widespread and dissemination of tumor at that recurrence stage. And the tightest data was really seen in the extent of ablation in radionecrosis, and we'll talk a lot about that coming up. When looking at the outcomes by the lesion treated by LITT, we see the calculated extent of ablation for each disease type, and 72% of patients achieved local control at a median of 7.2 months of follow-up. The time to recurrence differed quite significantly between the different cohorts. Time to recurrence was 39, almost 32 months for the entire cohort, with a median overall survival of about 17 months. And for recurrent GBM, median overall survival was around 7 months. And this aligns quite well with other reported outcomes for patients with recurrent GBM treated with other surgical or chemotherapy modalities. I would say very significantly, the median overall survival for newly diagnosed GBM was around 32 months. So it's quite significant. In a multivariate analysis, multiple variables were evaluated to determine if any clinical or treatment-related factors had an influence on outcome. And the one variable that did have a significant impact was extent of ablation. So a greater coverage of the ablated lesion predicted longer survival, indicating that results are similar as we think about it to gross total or extensive resection with more traditional surgical procedures. So the extent of ablation data is shown here in more detail. And you can see that the extent of ablation significantly predicted local control with a p-value of 0.009. An extent of ablation of greater than 85% predicted longer time to recurrence. Again, a very significant p-value of 0.006. And although the data is not shown here, there are a couple of other really key important points that came from the study. The first is that 100% of patients were discharged to home by postoperative day 2, clearly indicating that LITT may shorten length of stays over more traditional surgical procedures such as craniotomy. And secondly, complication rate was quite low at 4%, on all of which were transient. So these data really suggest that for patients with either treatment failure or tumors inaccessible via conventional open surgery, LITT remains a very versatile adjuvant treatment option. So the next study, again, is a single institution experience published by the MD Anderson Neurosurgery Group just earlier this year in 2021. The aim of this study was to describe the safety and efficacy of LITT for recurrent and newly diagnosed GBM, again, at, of course, a large tertiary referral center. So this was a retrospective study for patients receiving LITT between 2013 and 2017. This includes 69 patients with glioblastoma that received LITT. Median age was around 56. Median tumor volume was about 10 cubic centimeters. And most patients had recurrent GBM at around 70% of patients. A vast majority of them were MGMT promoter unmethylated at 84%. And of course, as would be expected, most had IDH wild type status. Medical management post-LITT included chemotherapy and about 2/3 of patients and radiation and a little over 1/4% of patients. So this is kind of a busy slide with multiple overall survival and progression-free survival Kaplan-Meier curves. The Kaplan-Meier estimate of median overall survival for the series from the time of LITT was approximately 12 months, and the median progression-free survival was approximately 4 months. These curves here show the potential influence of different clinical and LITT-related variables on outcome, as would be expected, younger age, female gender, and in this case, more interestingly, post-LITT chemotherapy were all associated with an increase in median overall survival. This is interesting given recent data that also suggests that post-LITT chemotherapy prolongs overall survival in patients with metastatic tumors. Post-LITT radiation increased progression-free survival, but not overall survival. And interestingly, the gross total ablation was not significantly associated with progression-free survival. So these data also suggest that these clinical variables continue to influence outcome in the setting of LITT, but very importantly, the post-LITT therapy equally plays an important role in potentiating the impact of this therapy. And as was suggested earlier, maybe it's due to the influence on the immune system or on blood-brain barrier disruption and potentially increased chemotherapy delivery. As I mentioned, the median overall survival for the group was approximately 12 months, and adjuvant post-LITT chemotherapy and female gender were predictors of longer overall survival. And in the multivariate analysis, as was mentioned, tumor size, tumor location, type of tumor, in other words, newly diagnosed or recurrent GBM, or gross total ablation were not predictors of overall or progression-free survival. So lastly, the study looked very closely at the safety of the procedure in this patient population. As you can see from the consort diagram, patient function was evaluated before, immediately after, and then 30 days post-procedure. You can see here that persistent neurological complications reported as new in only 4 patients, so approximately 5.7%, and worsened in about 13 patients, or almost 19%. But importantly, of those new deficits that were observed, most of them were transient. The data showing that complications do occur are not surprising, given the deeper locations of the tumor and, of course, the use of LITT in patients that have exhausted other therapeutic options. And I think some of the data that Roy presented earlier about how surgeons are getting more experience with the procedure in these very complicated cases probably will lead to lower complication rates if we were to look at more recent data. Importantly, most patients were able to continue adjuvant therapy post-LITT, consistent with the transient nature of many of the deficits. So the data from this study suggests that LITT can safely reduce intracranial tumor burden in patients with GBM who have exhausted other adjuvant therapies or poor candidates for conventional resection techniques. The procedure is safe and with low morbidity. So the last study we'll discuss today is a study by Dr. Bastos and the neurosurgery group at MD Anderson. And the objective of this study was to evaluate the predictive factors associated with local recurrence for brain metastasis following LITT. So this is of the 5 studies that we presented, really the one focused on brain metastasis. Like the others that we've reviewed today, this is retrospective data. The study focused on patients with brain mets treated with LITT at a single institution. And the patients were divided into 2 groups, essentially. So progressive disease post-radiosurgery, either as recurrent tumor or radiation necrosis. And this was based on the imaging appearance as determined by a very experienced senior neuroradiologist. New brain metastasis lesions were also evaluated, and the primary endpoint of the study was time to local recurrence. About 61 patients were evaluated, and the majority of the lesions, 87%, had previously been treated with radiation. So freedom from local recurrence at 6 months was 70%, at 12 months, 60%, and at both 18 and 24 months, over 50% had local control. And this slide shows the survival fraction of patients looking at 2 key variables. On the left, you see complete ablation. Patients who had complete ablation had a longer time to recurrence. And on the right, this is showing that patients with smaller tumor volumes, specifically less than 6 cubic centimeters, had longer time to local recurrence, again suggesting that these smaller tumors with a greater extent of ablation had more complete lesion control. This one shows 2 additional variables. The slide on the left is looking at dural-based metastasis. These tend to have lower levels of control. And on the right, tumor recurrence and newly diagnosed brain metastasis had shorter time to local recurrence when compared to radionecrosis lesions. This, again, suggesting kind of what we observe in the clinic, which is that LITT is incredibly effective at treating radiation necrosis. As previously mentioned, patients receiving systemic therapy within 3 months of receiving LITT had longer time to local recurrence. So here the group looked at multiple variables using a multivariate Cox regression model. As you see here on the table on the left, the hazard ratio for incompletely ablated lesions was 4.8, and for recurrent tumors, 3.1, and for patients not receiving systemic therapy, 2.5. So in this group, complication rate was approximately 26%. Again, probably similar to what we might see in this patient population treated with other surgical interventions. This analysis is really the largest series of brain metastasis patients treated with LITT, analyzing local recurrent rate and factors related to local control. And this tumor, again, is showing that incompletely ablated or recurrent tumor lesions were associated with high risk of treatment failure and were the major predicting factors for local recurrence. However, as was mentioned previously, systemic therapy after LITT was a protective factor regarding local recurrence. So this is a summary of the data that we've shared with you today. So as evidenced by treatment in the literature, in peer-reviewed manuscripts, over 4,000 patients demonstrating that LITT is an incredibly safe procedure. There's been detailed complication analysis in over 1,400 tumor procedures to date. And I think there's really extensive prospective multi-center registry data, real-world evidence that Roy shared earlier with the Lantern study, and then all of the single-center data that is reporting that LITT is highly effective. And it's effective in glioma, and some of the patients that are really great candidates, were those with biopsy only, good KPS, deep location, smaller tumor volumes, as was mentioned. And then, of course, recurrent brain metastasis and radiation necrosis. And as Roy mentioned, this is essentially set up like a stereotactic biopsy, and getting the tumor tissue is incredibly important in terms of differentiating progression from pseudoprogression or radiation necrosis, and this can be followed by treatment. The shorter length of stay with little, if any, ICU time, a quick ability to get into the adjuvant therapy, whether it's radiation or chemotherapy, are all really enabled by this procedure. And I would just mention here at the end that enrolling patients onto randomized controlled trials has been challenging. We all, believe this is important to have level 1 evidence for this this particular therapy, and we all are looking to be involved in those approaches. However, for a device and an approach that is approved and is commonly used in the clinic, it has been a little bit challenging to actually access those controlled data and to enroll patients on the clinical trials. But there's a lot of exciting work going on to continue to demonstrate the efficacy and really to hopefully open up new avenues of research that are going to have a major impact on patient outcome in the future. And we all believe that immunotherapy has an important role in the future of neuro-oncology, and LITT may be one of the foundational therapies to help enhance the local immune response. So combinations with immuno-oncology agents is an area of active study. And as mentioned, the blood-brain barrier disruption could enhance chemotherapy or other types of therapy delivery, and is a really great opportunity for further investigation. There's multiple ongoing trials in the communities right now. This is showing a list of 6 different trials with chemoradiation, combining LITT with hypofractionated radiation in newly diagnosed or recurrent GBM. And then, as I mentioned, there's interest in combinations with checkpoint inhibitors such as pembrolizumab or avelumab. And then there's also studies with LITT in combination with immunotherapy for recurrent brain metastases. Will continue to be data generated from this incredibly important Lantern study, up to 10,000 patients with long-term follow-up. And as I mentioned, we're all looking forward to having more controlled clinical data to increase the level of evidence and also further influence clinical adoption of this therapy, which is so important for our patients. I'll hand it back over to Roy to go through some of our cases. Thank you.
So we're going to review 3 cases and talk about how we integrate these data into our clinical practice. And we'll talk about a newly diagnosed case of an unresectable GBM and give you an idea of how we incorporate this into the upfront setting for glioma. This was a 69-year-old male who presented with intermittent left arm numbness and tingling consistent with seizure, new onset seizure. MRI showed a small ring-enhancing lesion concerning for primary malignancy, which we'll look at on the next slide. Stereotactic biopsy was performed and confirmed GBM. LITT was recommended and performed within the next 2 weeks. Prior to LITT, final pathology returned glioblastoma, IDH wild type, and MGMT unmethylated, and the patient began concurrent chemoradiation within 6 weeks of the initial stereotactic biopsy. This is the initial imaging for this patient. So we see a small ring-enhancing lesion with surrounding flare in the premotor cortex, just anterior to the primary motor cortex on the right side, contributing to these clinical seizures. A deep lesion that could be accessible surgically, but we'll be going through potentially eloquent cortex or adjacent to eloquent cortex and in potentially important motor fibers. And so this was felt to lend itself favorably to LITT. It's small, it's deep, patient had excellent performance status, 3 of those clinical features that Dr. Groot just reviewed. This patient got imaging about 6 weeks into therapy, and again, LITT was performed for that lesion. There was no delay to initiation of concurrent chemoradiation. The patient's therapy and radiation began within 6 weeks of initial biopsy, so no delay. And again, some of that is the short hospitalization and excellent recovery for the patient. And this is a typical image of what you would see within the first 6 to 8 weeks after laser therapy. There's a small, what's been called an eggshell ring of enhancement around the zone of ablation, which you can see on the axial and coronal post-contrast scans with minimal surrounding edema on the flare here in this area of ablated tissue, which is very typical for imaging post-LITT. Adjuvant therapy was initiated in April, and I'll show you the scan at the initiation of adjuvant therapy. The patient did suffer several breakthrough seizures requiring adjustment of anti-epileptics and was on and off of steroids, which is something that we can see and I have seen in these patients, and subsequently developed radiographic progression. And here's the imaging on the left at the time of beginning adjuvant therapy. So very typical for what you would see for a patient who's undergone a craniotomy. a small resection cavity that is beginning to involute following laser therapy with some surrounding edema, and the patient was put on steroids at that time, and subsequently we see recurrence on the right side. So some take-home points of this case: I think that times when I bring patients to tumor board at initial diagnosis in the upfront setting for LITT, again, are small lesions, less than 3 to 4 centimeters, in patients with good performance status in a deep location, potentially adjacent to eloquent cortex. And this patient did quite well without persistent or permanent motor deficit and tolerated LITT well. I think the second thing to see here is that LITT does not interfere with our ability to interpret imaging in the adjuvant setting, as you can see here. And so in terms of treatment decision-making, we don't see complications or difficulty with interpretation of imaging, more so than we already do and consider for these patients. And I think most importantly here, there was no delay to the initiation of concurrent chemoradiation for this patient. The patient was able to get biopsy followed by treatment with LITT and initiation of therapy well within what we would consider standard of care for these patients. So in our second case, let's talk about LITT in the recurrent setting in a patient with recurrent GBM. How do we interpret the data that we saw in this setting? This is a 64-year-old male with a history of follicular lymphoma who presented with a new onset, acute onset of aphasia, was found to have 2 left frontal lesions, one enhancing and the other non-enhancing, and had stereotactic biopsy that confirmed anaplastic astrocytoma, IDH wild type, and MGMT methylated. He received concurrent chemoradiation standard of care with 4 cycles of adjuvant Temodar, and then did findings concerning for progression, and we'll look at that at the margin of the radiation field. So here's his initial imaging. We see a multifocal, or really multicentric lesion, which you can see on the coronal flare here, these 2 areas, one with an area of enhancement. This was biopsied, and biopsy was read as anaplastic astrocytoma. The patient was treated with concurrent chemoradiation and 4 cycles of adjuvant therapy and developed 2 new enhancing lesions, which you see here at the margin of the radiation treatment field. I think this was around the 35 gray isodose line. And so there was question of whether this was pseudo-progression or progression. And so the patient underwent stereotactic biopsy followed by LITT. And I think that speaks to our ability to both diagnose what's going on with these patients and then administer a therapy. And also reminds us that 2 lesions can be treated successfully with LITT, and this was approximately the trajectory that was taken to treat both of these lesions in one treatment and in one pass or trajectory of the laser. The patient, at the time of discussing the need for surgery and LITT, didn't want surgery. And when we discussed the procedure involved in LITT and the 1-day hospitalization and these sorts of things, the patient was more amenable to that discussion. And so again, biopsy was performed and confirmed progression to GBM. Those 2 lesions were treated with LITT. The patient was in the hospital for 1 day and quickly released and was able to begin chemotherapy within weeks of the laser therapy. He was treated with dose-dense temozolomide for 9 cycles and did subsequently recur out of field and out of the area of LITT treatment. And this was that area of recurrence. We see a right temporal out of field recurrence at second progression, and a very typical appearance of what you see in an area treated with LITT, with a small area of residual T1 and minimal flare. And again, speaks to the ability to achieve local control in the recurrent setting in patients, and in this patient with molecularly favorable lesion, and who was able to initiate therapy at recurrence to control disease. All right, John, I'll turn it back to you.
Great, yeah, thank you. So the last case that we're going to present today is a case of presumed mostly radiation necrosis. So this is a patient of mine who was diagnosed when he was 59 with a right temporal lobe glioblastoma. This was IDH wild type MGMT promoter methylated. He was presented with a seizure back in 2014. So he had a gross total resection of the enhancing disease back in 2014. That was followed by the standard concurrent chemoradiation to 60 gray with concurrent temozolomide, and then we did 12 cycles of adjuvant temozolomide. The patient was on surveillance for the following 4 to 5 years without any evidence of change on his MRI scan. So he was really very had a really great response to that initial therapy. But starting in June of 2020, and even before that, he started to show increasing enhancement. And this, we were quite concerned was tumor, given the fact that he hadn't been treated for the last 4 to 5 years. But also we performed, sort of the typical advanced brain imaging, MR spectroscopy, perfusion, and there was some suggestion that at least some component of this enhancing lesion was actually treatment related. Now, the patient hadn't had radiation in 5 years, but we do occasionally see this. And so we wanted to proceed with a biopsy. And of course, the decision was, if we're going to biopsy, we should go ahead and perform the LITT procedure. This was done in June of 2020. It's been almost a year now. He's doing very well. And I'll kind of go through the clinical course after I show you the sequence of scans. So this is the trajectory. I apologize, this is a little bit hard to see, but you can see the trajectory of the probe into the lesion. This kind of gives you an idea of the size of this lesion here, 3 centimeters or so, and very easily accessible through the stereotactic guidance system with pretty much a near gross total ablation of the lesion. And this is kind of the sequence of scans on the far left, September of 2019, where there was really very little, if any, change on his MRI scan. April of 2020, so 6 months later, you can see in that deep sort of right parietal region, posterior temporal, and then you can see it enlarging even further a few months later in June, right before the procedure. The patient then had, as I mentioned, the LITT and with the biopsy, and then had the LITT procedure performed. Initially, after the procedure, there was a pretty significant increase in edema. The patient is left-handed and had some significant language difficulty. He had to stop working for a few months. We put him on high doses of steroids, and then we're able to taper that off over the next couple of months, so that you can see on the far right-hand side there in April of 2021, the lesion is smaller. He's actually back at work. He's back to running half marathons. He runs about 20 miles a week, and is doing really well. And the biopsy at the time of the procedure showed predominantly necrosis with one small fragment of glioma. We have not initiated any additional treatment since the LITT procedure, with the sort of impression that the LITT took care of whatever tumor there might have been in that lesion. So in summary, really, I think we've demonstrated today there's quite strong safety data. There is also very strong efficacy data, both from the Lantern Registry prospective studies as well as multiple single institution studies involving very large numbers of patients. The evolving body of evidence, we think, supports the use of LITT in glioma and also in disease progression post radiosurgery for brain metastasis. As we've, I think, mentioned multiple times, LITT is a really excellent therapeutic modality that can be used following biopsy. And of course, that biopsy is critical to help with prognosis and to sequencing of additional therapy. There's very favorable hospitalization data with length of stay being quite short, 1 day or less. And this is really ideal for the treatment of small lesions less than 4 centimeters. There's great evidence, I think, to demonstrate that you can have very effective local control, which of course is dependent on extent of ablation, and the very rapid recovery allows for early initiation of chemotherapy. And in our hands really has been ability to sort of defer the use of bevacizumab until later, or steroids, particularly in those patients whose pathologies are necrosis and where patients might be more steroid dependent. And as I mentioned, there's no need to delay of any kind of additional anti-tumor therapy following the procedure, which really allows for very easy integration of this treatment into the management of patients with gliomas and brain metastasis.